Good afternoon, everyone. Am I audible? Right. Thank you. Right. At the outset, I would like to thank the HDSI founding members as well as the HDSI NIMHANS team here for giving me an opportunity to communicate and provide support to the HD in this interdisciplinary approach in management, in evaluation and management of HD. So I begin by asking this question again. We know the title, right? So is it actually hard for a person with HD to speak? Is it actually hard for a person to swallow? For a person with HD to swallow? And we know very clearly the answer is yes. So I'm here to talk about these two complex acts of the human systems. There's a lot of, there's hearing, there's auditory processing, there's a thought process, there's a planning for the movement, and then the final execution of speech that happens. So it's not that, as simple as one would say. Very often, there's another aspect to it. People always say that, okay, it's after all speech. They push it aside. But let me tell you, it is the most complicated functions and requires a lot of, in-depth evaluation and the need assessment for the person, with HD. Does he need speech or not? Doesn't need speech, etc. So all these things have to be looked at when we talk of speech in HD patients. So let me let's look at this, speech impairment a little more closely. Now we know that what happens, that speech can get affected more often after the onset of other symptoms, right? So you have the motor symptoms, or you can have, some mood disturbances or some memory issues, and then, as a result of that, the speech can be affected. So the identification of a speech impairment can be much later when compared to other symptoms. But it is only in a few patients that you see that, okay, the dysarthric, speech output is very clearly evident at onset along with other symptoms. So now if the speech is impaired, very often you see an unpredictable breakdown in their articulatory production. So there is a distortion in articulation. When you talk of articulation, we are talking of phonemes, the speech sounds in a language. So they are very distorted, right? And they break within a word itself. There will be a pause. So in other words, for example, if I would say the word Bengaluru, I have to say it in a continuous stretch. It lasts for a few milliseconds. But in them, what happens is there could be a break. And this break, the way it is produced, can have a distortion. So if I would say, Bengaluru, what happens to the listener? The listener, raises the eyebrow, is wondering why a person is speaking. Of course, they do give a chance again to the speaker and say, okay, let me ask the next question. So they will ask the next question. They say, can you tell me about NIMHANS? So now I have to say a few things about NIMHANS. So I say NIMHANS is in Bengaluru. Then if I pause, what happens? So again the listener is wondering. So I have two more sentences to speak. I say NIMHANS is accessible through, one can reach through public transport or private transport, but there's no airlift directly to NIMHANS. But so what did I do? The second sentence was more continuous than the first sentence. So this is what. So if it is continuous without much breakdown, then the comprehensibility or the understandability is far better. But then in persons with HD, what happens is this break can happen in unrequired places too. We often pause after a sentence or within a sentence to convey a certain meaning. But if this pause doesn't happen in a particular way, then yes, we say that yes, the speech is affected. And this is the most common characteristics superficially that one would see. So this needs an investigation and for us to see which of the subsystems of speech are affected. We know that it's not just, a set of teeth, a throat that produces the speech. So you have the respiratory reserve for speech, you have the laryngeal subsystem for speech, you have the velopharyngeal competence that is required, the articulated production, all this, the competence of all this, along with another system which is called the prosodic system, which is not specific. It is again, that is the variation, the inflection, the tonal patterns in speech, the stress in speech. So all this tend to get affected in persons with HD. So an in-depth evaluation of these is required in persons with HD. Now, so this is on one side. So to give you another significant characteristic that is there in them is that one would see some kind of an explosive output. So apart from the breakdown, there's an explosive output. So suddenly some portion of the word alone is suddenly very loud, and the rest of the part, the remaining portion of the word is kind of, has a low volume. So what happens then? Is can the listener understand, or does the listener again raise the eyebrow? So all these things come into the picture when we talk of, the speech characteristics of a person with HD. So we know very well that initially in the preclinical phase, or in the initial early phases, the symptoms are very, very mild. So then what happens with advancement? So in the mid stage and in the later stages, it advances and it reaches to a stage of, it would progress from mild dysarthria to moderate to a severe, to a person who is unable to articulate or anarthric. So then what happens to the communication? We still have to maintain communication with them. That is the most important thing. WHO ICF very clearly tells us that it is important to analyze not just the body structure and function, but also look at the personal factors, the environmental factors, all these. Now we know that apart from, it is not just causing a dysarthria component, there are also other factors. For instance, if there is going to be a depression, the person is not going to speak. So then what happens? So it is important for us to analyze whether the speech is a dysarthric or it is going to be related to some other reason. So the speech is not yet dysarthric. So we need to determine these factors. What happens when there's a cognitive decline? Let me add that there is going to be an added linguistic dimension to the deficit in speech. So what do I mean by this linguistic dimension or a language dysfunction? So it means that, the word output is reduced, the meaning of the word can be incorrectly interpreted. So in other words, the comprehension also starts getting affected once there is a cognitive decline. So what is the net result? The net result is that the speech is definitely affected. So it's important for us to look at speech from various angles and then decide the dysarthria, or is it just a dysarthria, or is it, there is an associated acquired language disorder in them that we see that is very evident. Now, I would like to, one of the reasons why we need to look at it more, in depth is because we speak at the rate of 200 words per minute, and we speak, through the day. Communication happens through the day. So this is the reason why we need to analyze whether the deficit is, is just momentary, it is situational, or is it, across all situations. So that is what decides a lot more. That's where, we look at whether, it is only in the clinic that did the person, has shown the dysarthric component, or did the person, as soon as he woke up, did he have a dysarthric component, then subsequently speech was much better because the respiratory initially the respiratory support was insufficient, later on it became better, so forth. So all these matter a lot when we talk of speech and language. Now, given that we know that speech is affected, now does it affect the person's work, because the person is working? Can he continue to work or he cannot work? So all these, that environmental factor variables have to be taken when we say that yes, the speech is affected, and so there is an impact of this. So what is the final impact? So WHO ICF, we can do a assessment, communication assessment for them, and then see whether it affects various aspects which are related to speech. Now, given that if it is a mild dysarthria, so are there strategies to enhance them? Yes, definitely. It is possible, provided there is no associated emotional issue or any other factor. So then we can try to enhance, improve the speech quality. So ultimately we are looking at speech quality in the person. So, but then if the person is not cooperative, if the behavioral disturbances, lead, then what happens is we will be unable to execute any of the dysarthria management programs that is there. Now, so on one side, yes, the patient characteristics, and second side, on the other side is the listener. So the listener needs to pay a lot more attention, be a lot more patient, which we have been doing. Ours is a society where still, the HD person lives in the family. They are not really, gone out. So they are in the family. So there's a lot more advice that is given to the family members in terms of how to manage when the person has dysarthria. So how much they need to listen more. They may request for a repetition. So the patient needs to repeat. So a balance between this is what that keeps the communication going. So a dysarthric component is there, but the balance is definitely required so that the communication is not just for you, for a very superficial thing. It could be for the most important things. For example, it could be bank related documents, it could be paying bills, or it could be, someone, their child or somebody who's gone out and is to come back. So there is information related to that. So it could be on any of these issues, simplest of the issues which happen in every household. So in order to maintain the communication, it is important for us to enhance this aspect. So what we emphasize is enhance communication in them. So that is one. And now what happens when a person becomes, absolutely someone who does not have any speech? So look definitely for alternate modes of communication. So is the person communicating through gestures? Can the person communicate through gestures? Does the person need assistive technology for communicating? A small screen that we have on the mobile, it requires a finger touch. A person with so much of movement disorder will not be able to, touch somewhere to communicate, okay, look, I need to go use the washroom, I need to sleep, I need the fan on, I need to switch off the fan, is not possible. So you may have to provide appropriate assistive technology. The screen related to the assistive technology has to be appropriate, and these are all high techs. So if you do not want technology of this type, you can have the simplest, that is low tech or no tech. So just use, a board and the communication board, and then the person has all the required communicative pictures there, provided the person can identify still, the cognition has to be intact for that. And then he or she just touches, and then the communication happens. So such alternate modes. So speech is no longer functional in them. So what happens is the alternate modes of communication these need to be used in order to maintain communication. They may have pain, but they are unable to tell us verbally. So maybe they can show us. We can have pictures of, different parts of the body to ultimately, and they are going to point to us, look, the pain is here, and adjust my leg, adjust my head. So you can have pictures of these, and or the caretaker possibly can ask these questions. So this way, using gestures, using minimal communicative output also, we are able to establish rapport with the patient and see that, the communication for all the basic requirements keep going. So this is the motive ultimately. So my request to all the HDSI group is, if there is any issue in communication, please do consult. So let us see how we can solve this. It sounds very simple, but it may not be as simple as what it looks. One needs to communicate in various situations. So we do not know where the deficit is. So an analysis of that would help us look at, communication. So now you can see I moved from hard to speak to even hard to communicate. So that's the main thing. So let us focus on communication is what I would say. Now coming to the next thing, which is hard to swallow. Yes, again, as I said, there's an intricate neural network which is supplied to the muscles, and you have the different structures which are involved. There are 3 phases of swallowing. There's an oral phase, there's a pharyngeal phase, there's an esophageal phase. So all these phases are need to work efficiently in order to even swallow a saliva. Now, if you look at dry swallows, or what we call a swallow of saliva, it is 1 to 2 times per minute. Now, what happens in persons with HD is that now they have something in the mouth, but they are unable to execute a swallow. Now, there are 2 issues. One is, at some point it is voluntary act, and subsequently swallowing becomes involuntary. Now, that also gets compromised in them. So when we say that, yes, I have used, now I would like to just take a sip of water, then what happens is, yes, the person takes and it's there in the mouth, but then what happens is, maybe they are unable to regulate the movement posteriorly. The tongue is unable to push it posteriorly because there's a lot of involuntary movement of the tongue. Once they close the mouth, we have no clue what's happening inside. So that's when the problems. You cannot, put them for a test every time. You need to have about 2 bottles of water at least a day, right? So given that, so we are unable to make out, but still there are some strategies through which we can make out that yes, the person has swallowed or the person has not swallowed. So it's important to look at hyolaryngeal movement to see whether there has been a swallow. So this it sounds very simple that yes, it's okay this time, fine, this cup of water he's unable to drink, maybe he can take it again next time, maybe there's some issue, but it's not that. It is we have at least 2 meals a day, and two I would say 2 complete meals a day. We have 2 small meals a day, and then we have, in case there's going to be pills that one needs to take, that is also required. So when I say meal, it includes both your solids as well as the liquids, so everything. So just imagine, and that eating and swallowing is also a very social activity, right? So in all these cases, if any of these stages are affected, then there will be a delay in swallow. The time taken will be more. So give them more time. Let us analyze the problem. Is it at the oral level, at the pharyngeal level? Where is the problem? So can we reduce the spillage? Can we control, if we reduce the intake, the quantity of intake? Generally what we do is, if someone needs to have, let us say a breakfast which has about 2 idlis, you would take, I would say, if someone says, come on, quick, I need to, there's a taxi that's coming, we would just finish it in 5-10 minutes, right? But what happens in them? So we cannot, we cannot push them through, even if it is a mild stage, because very often they will have a delay pharyngeal swallow. You cannot push them to swallow quickly. So you need to give them the time to eat. So the bolus management is very, very important. All this is required because we are controlling aspiration in them. So we know that the risk of, if there's a risk, they are at risk for aspiration, then there are a lot of other issues that follow subsequently. So that is why we say give them the time to eat, controls the bolus, so that they can take control of the movement, execute the swallow, and ultimately what we call as a safe swallow is executed. So this is the ultimate goal, so that the nutrition, hydration, and medication is, taken in. Right. So this is the basis of the whole issue. So I would again, so that is why we say yes, definitely it is hard to swallow. So again, when somebody has a problem like this, if someone does not communicate, then what happens? So you can see that there's a lot of link. Communication is linked to everything, right? So with these few words, I thank Dr. Sanjeev Jain and Dr. Meera Purushottam for giving me an opportunity to project my thoughts, my experiences. It's been at a very informal level, and thank you again.